Good day, I am Clinical Clerk Hani Leong and I will be discussing on acidosis and alkalosis. Acid-base disorders can be divided into simple or mixed. Simple acid-base disorders is when compensatory metabolic and respiratory responses are activated in cases of primary respiratory and metabolic disturbances respectively. Mixed acid-base disorders, on the other hand, is the presence of independently coexisting disorders and not merely compensatory responses. This is often seen in critical care units, which may lead to dangerous extremes of AH. Diagnosing acid-base disorders involves 6 steps, which include first, obtaining arterial blood gas and electrolytes simultaneously. Second, comparing bicarbonate on ABG and electrolytes to verify accuracy. The blood to be used here should be drawn simultaneously prior to therapy. Third is to calculate the anion gap, but to be corrected to a normal albumin concentration of 4.5 grams per dl. This is calculated by the formula anion gap equals sodium minus chloride plus bicarbonate. Fourth is to know the causes of high anion gap acidosis, including ketoacidosis, lactic acidosis, renal failure, and toxins. Fifth is to know the 2 causes of hyperchloremic or non-gap acidosis, including bicarbonate loss from the GIT or renal tubular acidosis. Sixth is to estimate the compensatory response. Seventh is to compare the change in anion gap and bicarbonate. And lastly, to compare the change in chloride to the change in sodium. Starting off with the first acid-base disorder, which is metabolic acidosis. This occurs because of an increase in endogenous acid production such as lactate and keto acids, loss of bicarbonate such as in diarrhea, or accumulation of endogenous acids due to inappropriately low net acid excretion by the kidney, especially in chronic kidney disease. Effects of metabolic acidosis in the body depends on the rapidity of onset and severity. Common complaints include fatigue, nausea, vomiting, shortness of breath, dyspnea on exertion. Deep respirations may also be detected. Since metabolic acidemia is associated with vasodilation, hypotension and tachycardia may also be noted. Lastly, depressed CNS function presents as headache, lethargy, stupor, and sometimes leads to coma. This figure shows the 2 major categories of metabolic acidosis, including high anion and non or normal anion gap. The 4 principal causes of high anion gap include lactic acidosis, ketoacidosis, toxins, and renal failure. Initial screening should include first, signs of elevated lactate levels to include hypotension, shock, cardiac failure, leukemia, cancer, and drug or toxin ingestion. Second is to assess if diabetes mellitus is present for diabetic ketoacidosis. Third is to assess for alcoholism or increased level of beta-hydroxybutyrate in alcoholic ketoacidosis. Also for urinalysis to inspect for oxalate crystals in ethylene glycol intoxication. For evidence of drug and toxin ingestion in the history, as well as measurement of ABG to coexistent respiratory alkalosis for salicylate intoxication. Lastly, for clinical signs of uremia to include BUN and creatinine testing for uremic acidosis. For non-anion gap acidosis, bicarbonate loss can be through the gastrointestinal tract and diarrhea, or drugs such as calcium chloride or magnesium sulfate. Alkali can be lost in renal tubular abnormalities, with proximal and distal renal tubular acidosis presenting with hypokalemia, type 4 with hyperkalemia, and chronic progressive kidney disease with normokalemia. This disorder may also be due to drugs and renal insufficiency, and lastly, miscellaneous causes such as acid loads and the like. Generally, metabolic acidosis, specifically with dose pH of less than 7.10, is managed with IV administration of 50 mg of sodium bicarbonate diluted in 300 ml of sterile water over 30 to 45 minutes during the initial 1 to 2 hours of therapy. This requires careful monitoring of plasma electrolytes, specifically potassium. Initial goal for this is to increase the bicarbonate levels to 10 to 12 mm per liter and pH to approximately 7.20. This figure summarizes the treatment for high anion gap acidosis, specifically for lactic acidosis, ketoacidosis, toxins, and chronic kidney disease. On the other hand, this figure presents the specific management in non-anion gap acidosis for non-renal causes, the different types of renal tubular acidosis, and adrenal insufficiency. Now going into the second acid-base disorder, which is metabolic alkalosis, which is defined with elevated arterial pH, serum bicarbonate, and partial carbon dioxide due to compensatory alveolar hypoventilation. Metabolic alkalosis with pH up to 7.5 is usually asymptomatic. However, when pH levels exceed 7.50, clinical features are associated with metabolic encephalopathy, such as confusion, obtundation, delirium, and coma. On the other hand, symptoms of hypocalcemia may be seen, such as tetany, paresthesias, and muscle cramping. Other important findings in this acid-base disorder include cardiac tachyarrhythmia and hypotension. This figure shows the different causes of metabolic alkalosis, which are categorized into four, such as exogenous bicarbonate loss, effective ECFV contraction, ECV expansion, and gain-of-function mutation in sodium channels. With this, it is important to assess the extracellular fluid volume, recumbent and upright blood pressure, serum potassium, and renin-aldosterone system. Treatment of metabolic alkalosis is catered to correct the underlying stimulus for bicarbonate generation and to remove factors that sustain inappropriate increase in bicarbonate reabsorption. For the first goal, this can be done with hydrogen ion loss in the GI managed with the use of proton pump inhibitors or discontinuation of diuretics. For the second goal or aspect, when ECFV contraction or potassium deficiency is present, isotonic saline is recommended to reverse alkalosis. If conditions preclude infusion of saline, renal bicarbonate loss can be accelerated with acetazolamide 125 to 250 mg intravenously, which is effective in patients with adequate renal function but can worsen potassium losses. 0.1 hydrochloric acid or dilute HCl has been advocated, however this is prone to hemolysis, thereby must be delivered slowly in the central vein. The third acid-base disorder is respiratory acidosis, which is the primary elevation in partial carbon dioxide with reduced arterial pH and variable bicarbonate concentration. This can be due to severe pulmonary disease, respiratory muscle fatigue, or ventilatory control abnormalities. Respiratory acidosis may be acute or chronic. For acute, the cellular buffing mechanism results with compensatory changes by which bicarbonate increases by 1 millimoles per liter for every 10 mm mercury increase in partial carbon dioxide. In chronic respiratory acidosis, renal adaptation increases bicarbonate levels by 4 millimoles per liter for every 10 mm mercury increase in partial carbon dioxide. Serum bicarbonate usually does not increase above 38 millimoles per liter. Clinical features of respiratory acidosis vary with regards to the degree and duration of the condition, underlying disease, and accompanying hypoxemia. A rapid rise in partial carbon dioxide may result to anxiety, dyspnea, confusion, psychosis, hallucinations, and may even progress to coma. Lesser degree of dysfunction includes sleep disturbances, loss of memory, daytime somnolence, personality changes, impairment of coordination, and motor disturbances. Lastly, vasoconstriction secondary to loss of carbon dioxide vasodilator effects may mimic raised intracranial pressure such as headache, papilledema, abnormal reflexes, and focal muscle weakness. Central causes such as respiratory center depression may occur with general anesthetics, sedatives, stroke, infection, and head trauma. Occlusion of airway with obstruction, asthma, anaphylaxis, inhalational burn, or toxin injury can result to acute hypercapnia. Improper mechanical ventilation settings may result to respiratory acidosis, specifically in cases where carbon dioxide production suddenly rises. Neuromuscular abnormalities result in respiratory muscle fatigue, leading to hypoventilation. Lastly, other causes including permissive hypercapnia minimizes intrinsic positive and expiratory pressure. Diagnosis of this disorder involves a detailed history and PE with assessment of the upper airway, chest wall, pleura, and neuromuscular function. ABG to measure partial carbon dioxide and arterial pH is also important. Pulmonary function study, specifically spirometry to determine any underlying lung disease, and complete blood count to assess hematocrit. Goal of management is to correct underlying disease and ensure adequate ventilation. Since acute respiratory acidosis is life-threatening, restoration of adequate alveolar ventilation is done by tracheal intubation and assisted mechanical ventilation. Careful titration of oxygen supplementation must be noted, especially those with obstructive diseases or chronic carbon dioxide retention, since aggressive and rapid correction may provoke complications with acute respiratory alkalosis. In chronic respiratory acidosis, although it is difficult to correct, its aim is to improve lung function. Partial carbon dioxide can be lowered gradually to restore its levels to baseline and enhance renal bicarbonate excretion. For the last acid-base disorder, we have respiratory alkalosis, which is the primary decrease in carbon dioxide with elevated pH and variable decrease in bicarbonate concentration. This is common during mechanical ventilation. Acute respiratory alkalosis causes intracellular shifts of sodium, potassium, phosphate, and reduces calcium by increasing protein-bound fraction. Bicarbonate drops by 2 millimoles per liter for every 10 mm mercury increase in partial carbon dioxide. Chronic respiratory alkalosis is the most common acid-base disturbance in critically ill patients and has a poor prognosis. 1 mm mercury decrease in partial carbon dioxide results in a 0.4 to 0.5 millimoles per liter drop in bicarbonate and 0.3 millimoles per liter decrease in hydrogen ion concentration. Features of respiratory alkalosis are related to the degree and duration of the condition and the underlying disease. Symptoms of acute hypocapnia, that is, partial carbon dioxide levels of less than 30, include dizziness, confusion, asterexis, hypotension, seizures, coma, and perioral or extremity paresthesias. Hyperventilation syndrome, on the other hand, may be debilitating with symptoms of paresthesia, circumoral numbness, chest wall tightness or pain, dizziness, inability to take adequate breath, and rarely with tetany. The following are the common causes of respiratory alkalosis that may be due to CNS stimulation, hypoxemia, drugs or hormones, and chest receptor stimulation. For drugs or hormones, salicylates are the most common cause of drug-induced respiratory alkalosis with direct stimulation of the medullary chemoreceptor. Progesterone leads to increase in ventilation with lowering of partial carbon dioxide. Methylxanthine, theophylline, and aminophylline stimulate ventilation. So this disorder may also be seen in hepatic failure with liver insufficiency. Management of this disorder is through alleviation of underlying disease. If the alkalosis is due to complication of mechanical ventilation, changes in dead space, tidal volume, and frequency can minimize hypocapnia. Reassurance, rebreathing from a paper bag in symptomatic attacks, and attention to underlying psychological stress may be beneficial for those with hyperventilation syndromes. Antidepressants and sedatives are not recommended in managing respiratory alkalosis. This would be the end of my discussion on acidosis and alkalosis. So here are my references. Thank you.